Hello everybody, my name is John Cranham. I'm the Clinical Director of the Dawson Academy. Dr. Maddie, your course director, has asked me to participate in your curriculum this year and do 5 sessions for you. My goal really is to give you a glimpse in the importance of occlusion, particularly with regards to running an everyday practice. My practice focuses not only everyday general dentistry, but all the way up to larger cosmetic cases and implant reconstructions. And what I hope you to glean from this class is not just enough information for you to pass your boards, but to really start to see how this topic is critical for you to be able to do dentistry predictably, profitably, enjoyably, and for it just to be part of the culture of what you do. By now, you've had a pretty thorough understanding of biologic disease, and hopefully you can lay a patient back and determine what teeth are savable, what teeth are hopeless, what teeth need maybe a filling, or what teeth may need crowns or replacement. But when we start thinking about this masticatory system, the stability and health of the temporomandibular joints, how that affects muscle function, and how ultimately muscle function can put pressures on teeth, one of the things I want you to think about is that the topic of occlusion is about force management. And when a bite is functioning properly, we will have harmony between the temporomandibular joints, the muscles that move the jaw around and close the jaw, and the anterior teeth and posterior teeth. And when the occlusion is out of harmony, in certain patients that can increase muscle activity, which can have a detrimental effect on the teeth, the muscles, or the joints themselves. So what I want you to think about is that we are going to be analyzing our patient not just by looking at the teeth and supporting structures, but we're also going to be looking at this masticatory system that Dr. Maddie's been talking to you about. And as we analyze our patient and maybe see a problem, we really want to start to understand if the problem that we're seeing might just be the tip of the iceberg. Because again, sometimes teeth which maybe have a little crack or a cusp that pops off might look like an individual tooth problem, but what we want you to see is that that may be a sign or a symptom of something much bigger. So we have to have some understanding of what we call cause and effect. That often the symptom that the patient is talking about or the sign that we are observing is always going to have an underlying cause. And to be successful in what we do, we have to determine the cause, the diagnosis, before we can start to determine what is going to be the appropriate course of treatment. So as I mentioned to you, causative factor number 1 is always going to be bacteria, microorganisms. They are going to be the primary thing, particularly at the dental school level, that you're going to be focusing in on. And of course, depending on the type of bacteria, that can manifest itself either as tooth decay or as periodontal disease. Causative factor number 2 is the occlusion. It's force. And if we have disharmony between the joints and the teeth, if we have the ability to rub on back teeth, as we'll show you, there are things that you will learn about that it can increase muscle activity, which will increase occlusal forces, which will cause occlusal overload, which is going to lead to the thing that we're going to call occlusal disease. Okay? So occlusal disease is the enemy. And the thing to realize is that if we have that occlusal overload or occlusal disease, it is always going to be the weak link in the system that gets the problem. And sometimes that can be the tooth structure, sometimes that can be the muscles, and as you'll see in more advanced lectures, that can relate to problems with the temporomandibular joint themselves. So our first goal in any treatment plan is always going to be about getting that mouth healthy. And when we talk about that, we mean from a biologic standpoint. We want to make sure that tissues are perfect, that every sulcus is cleanable by the patient, that they don't have inflammation. We want to make sure that every surface of every tooth is cleansable by the patient. and that the teeth are going to be individually strong. And if we do restorations, that they have cleansable contours. So when we do this examination of what we're going to call our complete care practice, we're of course going to do an oral cancer check, and we'll do our full probing, we'll do our restorative charting, your full mouth series of x-rays, but we're also going to be doing a thorough check of the masticatory system, which is our TMJ occlusal examination. That's the only way that we are going to be able to visualize that. And later in this series, I'll show you a TMJ occlusal exam in real time to be able to screen a patient for the things that are going on. And we don't want you to be intimidated by that or concerned about that. It should be something that you inherently do just as part of your exam, just like you do your oral cancer check. So we want you to start thinking about this concept of signs versus symptom. Remember, a symptom is something that a patient reports. A sign is going to be observable by you. An example might be tooth wear. So tooth wear into dentin often doesn't hurt a patient, but it's a sign of something. And it's maybe will stimulate conversations with your patient. It's something they should be concerned about. I want you to think about, we do this with biologic disease too. It's a reason we take bite wing x-rays. When you take a bite wing x-ray and you see interproximal decay, that is a sign of caries. The patients often don't have symptoms yet. We do that to catch disease early. We probe patients to look for early pocketing before they have a loose tooth or a sore tooth. So signs are something that we will look for. And a mouth that is completely healthy is one that lacks any signs of disease. That would be inflammation and some of the other occlusal issues that we'll talk about in a little bit. So the signs of occlusal disease that are most observable are wear. But I'll tell you that as we go through, we're going to identify these as wear, mobility, teeth that are mobile, in the absence of gum disease, so teeth that are loose from force, teeth that are changing position, migrating, so wear, mobility, migration, sore muscles of mastication to palpation, because muscles don't get sore from just chewing, and then change at the temporomandibular joint level in the absence of trauma. So if somebody's joint is changing and they haven't had a traumatic injury, it's often related to the occlusion. So we really identified those three parts of the masticatory systems, joints, muscles, and teeth, as we've gone ahead and do that. Remember, these signs of occlusal disease are almost always progressive. And also notice that signs of occlusal disease almost always precede symptoms. So teeth that are beginning to wear often don't have pain, but if they continue to wear, they often can get sensitive as they get further into dentin. People that are wearing their teeth might start to have sore musculature from hypercontraction. We'll talk about that mechanism later, and they can certainly have change at the joint level. So symptoms can be related to teeth, they can be related to the musculature, and they can certainly be related to the joint. Those are those three parts of the masticatory system that you'll be learning about. So what do you think is the most untapped need or opportunity, if you want to look at it that way, in most dental practices? With periodontal disease, it is the number one cause of tooth loss. And when you look at molars and we start understanding occlusal disease, most molars that are lost from periodontal reasons also have occlusal issues associated with it. It's the number one cause of patient discomfort, the number one cause of orofacial pain, the number one cause of patient dissatisfaction, the number one most misdiagnosis, the number one most undiagnosed problem, and that is occlusal disease. You will learn throughout the course of this course, you're going to learn more and more about that. And of course, our curriculum at the Dawson Academy for advanced dental education is that's what we really teach, is how to manage and handle these types of problems. Understand occlusal disease can be very, very early. That top middle slide is a good example of somebody that's just losing the cusp tips of their canines. Notice the distal of the central on that upper left slide. You start looking at erosion on that top right slide, and then really extreme breakdown in the front teeth with bruxism and combination of bruxism and erosion on the bottom right one. These are all occlusions that are not stable. And if you think about this logically, if we don't do something to change the occlusion or change the forces, if we just cover these teeth with crowns, they're just going to do to our teeth what they've done to their own teeth. And so what occlusion is about is being able to figure out how we can change the contours as we restore, or as we do orthodontics, or as we do orthodontic surgery, or as we do anything to the dentition, to be able to create a situation where the joints, muscles, and teeth will be in better harmony and muscle activity will be lower. But we will actually be able to decrease the forces to the dentition and ultimately be able to make things last longer. Okay? So all of these problems, if left alone, will progress. Remember that occlusal disease can cause sore, sensitive teeth. It's not just caries that can make teeth hurt. If muscle activity is up and people are grinding and bruxing, that can cause pulps to become hyperemic. That's one of the most common things that we can see. So certainly wear, mobility, migration, sore muscles, certain TMDs. You look at this guy and you look at the wear on his front teeth, and then look at the size of his masters, right? People who are bruxing and grinding and have certain types of occlusal interferences will actually increase muscle activity, and they will start to literally build up the muscles in the face, which exacerbate the problem. And this guy, of course, class 3 type bite, but somebody that is just flattening his dentition. Later in the class, we'll show you how he restored him and solved his problem. You've learned a little bit about anterior guidance. Haven't, you will. But this concept that when we slide laterally, we want the posterior teeth to exclude. And so if we slide laterally and the back teeth can rub, you're going to see that that increases muscle activity. This is a great example of a patient whose canines are in crossbite. So when she slides laterally, she is rubbing on her first and second bicuspids. And as we look at this patient, notice the non-carious cervical lesions, the abfraction lesions. You can get non-carious cervical lesions from brushing too hard with toothpaste. Those are often U-shaped lesions, but these V-shaped lesions are caused from increased muscle activity where the teeth are actually bending and we're losing tooth structure at the gum line. This is a patient that if we were to move the teeth back and create better canine guidance or anterior guidance, posterior disclusion, all terms you're going to learn about. In other words, if we get this patient off of their back teeth when they're going into excursions, muscle activity will decrease, and that will create an environment where we could restore these areas. If we were to just put composite in these areas and do nothing to the occlusion, what do you think would happen? Well, they would pop right out, and that is a common occurrence in dental practices. So be looking for that. Check your patient's disclusion patterns, and you can start seeing some of these things. So we're going to identify patients that have occlusal disease. The general and specialty patients we'll talk about later. But let's just say for now that to identify a patient that has an occlusal problem from one that doesn't have an occlusal problem really requires a thorough exam. But along with your oral cancer exam and your probing and your restorative charting, we're going to show you how to do a TMJ occlusal examination where you look at the different parts of the masticatory system. We'll also, of course, do a full series of films, and in our practice we also do photographs. But when we start seeing patients whose occlusion is not stable, there are sometimes things that we see happening to teeth. Maybe it's porcelain that's fracturing or has fractured and been repaired. A lot of buccal cusps pop off, and we're made to believe that the cusp pops off because there's an amalgam in the tooth. Now, there isn't any question that amalgam does weaken teeth, but we also know that if the patient slides laterally and can rub on an incline, that rubbing, that bruxing pattern with increased muscle activity can also increase the forces causing it. So as we look at a tooth that's fractured, we want to understand why. Is it possible for us to alter the occlusal scheme in a way that when we restore the area, it's not only going to make the tooth stronger, but it's going to better create harmony in the masticatory system? And that really is what this topic of occlusion is about. We look at Mariah, beautiful young gal. She's a dental assistant, worked with me for a number of years. And we start seeing a little bit of wear and tear. You can't see it here, but we can certainly see it on that canine, can't we? Look at tooth number 6 and notice how we've just lost the cusped tip. As we get closer, we can start to see how the upper and lower tip is gone. And what I want you to understand is if we see the wear and tear, we know that if we can see dentin, that the patient has lost 2 millimeters of tooth structure to get to dentin. And if you can get to dentin, we know that the wear, depending on the study, is 7 to 9 times faster. So enamel is extremely important. And what you're going to learn is if they're wearing out front teeth, almost always there's an interference somewhere in the back that the patient's grinding on that increases the muscle activity that causes damage in the front of the mouth. And we will show you that dynamic as we go along. Let's take a look at Ben. What you might notice already is look at the size of Ben's masters. His head is almost pear-shaped. And this is somebody that has some sleep apnea going on, but also is bruxing and grinding. You can see the wear across the lower incisors and canines. Upper canine to canine has been restored with resin, although it's failing. And he's also chipped some porcelain on a lower molar. Again, look at his smile. Look at the exposed dentin on the lower incisors. Look at the distal, wear on the distal of the laterals as well as the tip of the canines. This is somebody who's grinding back and forth. And yet in most practices, this will be looked at and kind of ignored because the patient doesn't have pain. This is a patient who's losing tooth structure at a fairly rapid rate. And what I'll tell you is that this is a patient that will only get worse over time. So learning how to talk to a patient like this, make them understand that there's a problem, and various ways to not only fix it, but fix it so that it'll be beautiful is a really fun part of what we can do. If we look at models of Ben, we have him slide around side to side. What you're going to see as we look at the back, he has no ability to disclude. All of the forces are on the back teeth. And so as he grinds side to side, as he go into sort of, this is straight lateral, but if he goes to sort of a lateral protrusive mood, he will be grinding on the back teeth while he's on the front teeth. And that is the enemy of a good occlusion. Remember, as we go laterally, we want the forces more up front. So take a look at him, and you can also start to know that notice he has no incisal embrasures. Why? Because as the teeth wear out, you lose some of the anatomy of those front teeth. Notice also how his lower incisal plane is concave. The canines are taller than the centrals. That is not normal, and that only happens by bringing the jaw forward. And you can also see as he brings the jaw forward how he's also running into a second molar in the protrusive stroke. Those are all things, indicators that cause the wear and tear. Tajaman is another one that is driven by aesthetics, unhappy with her smile. And at first glance, it doesn't look too bad. She has lots of different shades. But look at her lower incisal plane and look at how it's angled, how it's sloping downward. Look at how the wear is worse on the right side than the left side. Again, she is ready to pay you good money to have a beautiful smile, but how is it that we can predictably do that? What protocols can we do to do the aesthetic dentistry? This is going to require not only aesthetic design, but it's going to require some occlusal design. Also notice the abfraction type lesions that we're seeing up on the cervical third of many of the teeth. She also has some insufficient attached disc tissue that we're going to have to deal with. But these are fun cases. Right now, I just want you to think about that we just can't cover these teeth. We have to employ some strategy of force management. And that's what good understanding of occlusion will allow us to do. And this is, again, a case we'll be looking at in our 5th session to show you how we'll go through this protocol of creating something that will be beautiful but will also last a long time. We use some software to be able to indicate some of the things that we see, and while she has high aesthetic concerns, she also has a history of clenching and grinding. She has sore muscles on both sides to palpation. She's exposed dentin and the wear patterns. So she has parapuncture. She's not happy with her smile. Her joint is healthy, but she has a slight slide, and we'll talk about what that means later. But bottom line, her sign of instability is related to the teeth and the musculature, and that is something that we can absolutely help her with. We look at Monique, who's had a tremendous amount of restorative dentistry, but again, when we look at how she was restored, she's hitting on a couple of teeth. A little bit of an open bite here, kind of class 2. She hates how the porcelain looks, but she has some skeletal issues, and when we analyze her a little bit further, she actually has a temporomandibular joint that's changing. So her pain is related to the TMJ. And again, what you're going to see is creating stability at the joint level will be the first thing that we do in order to be able to then move towards being able to restore this patient properly. Take a look at the her lower right 3rd molar, and imagine as the jaw slides forward how that lower molar is going to slam into the back of the upper 2nd molar. That will create a huge protrusive as well as mediotrusive interference that we'll have you learn about. But pain and dysfunction is related often to how the teeth occlude and disclude. But Monique has a lot of problems. She's got 4 to 6 millimeter pockets, some tattooing on 8 and 9. She's got a class 2 anterior open bite. She has no anterior guidance. She's got working and balancing interferences. She's got mobility in the molars. 32 is hopeless. Bad shape of all the crowns. The upper and lower incisors are long and too far out. She doesn't like the porcelain. So where do we even start in a patient like this? Well, we better start with an understanding of where we're going. And a lot about what good occlusion knowledge will do for you is give you that roadmap of being able to design something that's going to be appropriate for the patient. Aesthetically, so the teeth look good, as well as occlusally, so that we can manage the forces. Again, we'll look at this case in our last session together. Sometimes we have accidents that can create issues. If you look at Alexis here, just look at her facial asymmetry. Notice how her chin is deviating slightly to her left side. She had a fall at 13. The little disc that's supposed to be between the condyle and the articular eminence and glenoid fossa is displaced, and she started to develop degeneration of that left condyle. And as that condyle shortens, her chin will deviate in that direction. In fact, you'll see the whole occlusal plane go that way. That limits her range of motion. It causes popping and clicking. She has pain when we load the joint. She has crepitus in the joint, and it will create very specific wear patterns. We will image that joint with cone beam, computerized imaging that allows us to look at the joint in 3 dimension, and she has degenerative joint disease in both joints. What I want you to notice, though, while she seems to have a fairly normal smile, you look at this picture, notice how the cant that she has to her smile going towards her left occlusal plane is higher than her right occlusal plane. That's because the whole jaw, upper and lower, is shifting in that direction as the joint breaks down. It will actually cause the molars and premolars on that left side, the maxilla, to intrude and create a steeper occlusal plane. So you're going to learn about that. You're going to learn about how important the condition and the position of the joint is on these types of patients and getting them, being able to have predictability and getting them well. Some people just come in for cosmetics, and you just look at this guy, and I hope that you have a feeling of a little bit of fear, but we'll look at him a little bit later and talk about how we can restore him and give him this what he wants. He's coming in with wanting a beautiful smile. But again, occlusal design will go hand in hand with smile design. And a lot of you may be intrigued by doing cosmetic dentistry and implant dentistry, but trust me, to have success with it, this class is absolutely critical for your success in those other endeavors. We're also going to talk about implant dentistry. This is Stefan's case, and we look at him. He's a person with a occlusal disease that where his mouth is pretty much at the end stage occlusal disease. And so when you look at his smile, it doesn't look too bad, but you look at it this way and have a full appreciation for the bone that's being built up around these teeth. Somebody that grinds their whole life and doesn't rock the teeth out. He's worn the teeth out. They've been restored 57 different ways. But we'll look at his case and show you how we treatment plan a case like this and restore him with an all-on-4 type treatment. He actually put 6 implants on the top and 5 implants on the bottom and did tori removal and all. But we have to, again, have a full appreciation that just trying to go in there and put some implants in and not have some sort of protocol in place to manage these forces will mean that he would just do to our restorations what he's done to his own teeth. The concept of an overclosed bite, we'll talk about that, vertical dimension. But this is what end-stage occlusal disease looks like. And challenging, they're fun, but it takes a great deal of knowledge, which is going to start right now in this class. The thing I want you to look at him is you saw what he looked at the end, but he brought in these pictures, and I want you to just look at him and tell me what you see. Look at that upper left picture when he was a freckle-faced young guy, and take a look at his central incisors, and you're already seeing facets. So he was already had some instability as a young kid, and certainly this is probably in his late 50s, early 60s, and it's probably in his early 40s. But this is something that was going on and on and on. It wasn't recognized, it wasn't treated, and it finally got to the point where, you know, nothing can be saved. And it ended up with really a massive surgery for us to be able to give him back something that was fixed. When do we pick up these TMJ problems? You look at this gal's face, look at the size of her master, her jaw again. She came in for a cleaning. We went through the history. She's got clicking and popping and pain. It had never been diagnosed. She'd been seeing many physicians and getting injections with Toradol for pain. She's had some Botox in her masters, and no one has ever really identified the problem, which was just kind of classic occlusal disease. Very good-looking dentition, but a jaw that's falling back and just breaking down over time. And in this picture, you can start to see some of the wear and tear on the lower laterals and canines. So how do we start with a patient like this? Well, you start with identifying what it is and then following specific protocols that you are going to learn. Last one we'll just look at is to think about. This is a patient that's coming in, again, purely for aesthetics. You look at her, she doesn't seem to have a lot of occlusal disease, just sort of some dentistry she's not very happy with, veneers that don't look very good. And so what I want to ask you is it possible to improve her smile and to increase the stability of her occlusion, to actually manage the forces better? Absolutely, we absolutely can do that. But the other thing I want you to think about is this question: is it possible to improve her smile and decrease the stability of her occlusion? And I'll tell you, I see it all the time. People coming in for second and third opinions with work that has just been completed and veneers are popping off and fracturing, and they want to know why. But they never seem to have any problem before, and veneers go on it, which shouldn't seem to alter the occlusion, and they do. And so what we want to share with you is that we can absolutely increase the stability of occlusion. We don't have to decrease, and we do that by designing, thinking about very specific principles of creating a scenario where people can't rub their back teeth. That concept of anterior guidance, lines in the front and dots in the back. So again, I just want to have you think about that. Start thinking in a little bit more detail about the components of the masticatory system. And as you evaluate your patients, just be open to looking at the joints, looking at range of motion, and listening for noises, clicking and popping, and start getting an understanding of what's sort of normal and what we should be concerned about. Palpating the muscles to feel what normal muscles are like versus muscles that are over-functioning and are sore. And then let's take a look at the teeth for wear, for mobility and migration. And I think if you do, you'll start recognizing occlusal disease. And as we move forward, we can start to learn what to do about it. So I hope you found that enjoyable. I look forward to seeing you next time. And until then, I'm Dr. Cranham, and good luck with this class and everything else you're going on